All right, well, good evening, everybody. Welcome to this Central Regional Cancer Program. And my name is Alan Kaplan. I am a family physician in Aurora, and I'm the Central Regional Primary Care Cancer Lead. And I have the exciting role to moderate this evening's conversation. And you see the topic there, 2SLGBTQ and cancer screening, and it's an interesting combination. And we have an excellent expert to talk to us about that tonight. Next slide, please. We will start off with a land acknowledgement that our Central Regional Cancer Program, which is located at South Lake Regional Health Center, recognizes and acknowledges the lands originally used and occupied by the first peoples of the Williams Treaties First Nations, as well as other Indigenous peoples. And on behalf of the Central Regional Cancer Program, we would like to thank them for sharing this land. We also want to acknowledge the Chippewas of Georgina Island First Nation as our closest First Nation community and recognize the unique relationship that the Chippewas have had with the lands and waters of these territories. They are the water protectors and the environmental stewards of these lands, and we join them in these responsibilities. Next slide, please. This is being recorded. We prefer if your microphone is muted. I don't mind if your camera is on. That's fine if you want us to look at you as well. Just be careful if you're eating while your camera's on. The chat box says will not be available, but I just tried it and it did work. So if you have something to comment on, put it in the chat. But if you have any questions, please put it in the question and answer function. It's a little easier for us to moderate questions in there. So questions and answers go there. Or comments or requests can go in the chat box, or you can email Shoshana at the address there if you have any questions or you're having any problems with any audio or any issues like that. All of these slides, as well as the recording link and resources that Ed has put together, will be sent to the attendees after the webinar. There will be an evaluation survey at the end of the webinar. Please take a moment to do that. It'll be sent to you by SurveyMonkey afterwards. And in addition, this is accredited, and you'll get a letter of accreditation at the email that you're registered at to claim the credit within 1 week after the session. It'll come with a session number. You have to go to the college site to do that. Next slide, please. So this is worth 1 credit per hour group learning program. So for the CFPC, and has been certified by the Continuing Professional Development Temerity Faculty of Medicine, University of Toronto, for a 1 main pro credit. And I now have the honor to introduce Ed. Dr. Kucharski is a palliative care physician at Toronto Grace Health Center. He's also the Chief Medical Officer for Casey House Hospital, which I'm sure he's going to tell us about. Throughout his career, Ed really is focused on the health inequities of marginalized populations. He's taught about 2SLGBTQ, and for those of you that don't know what that stands for, it stands for two-spirit, lesbian, gay, bisexual, transgender, and queer, in terms of primary care at various medical school centers and conferences. He also has a real interest in quality improvement and has shared his experience at the Ontario Health Association patient safety course on several occasions. He has a long relationship with Cancer Care Ontario. He was a regional primary care lead for the Toronto Central, Lynn South, and for of CCO, and practiced comprehensive primary care for close to 2 decades. So he really has been in our shoes and knows all of our shoes. He went to medical school, University of Ottawa, and completed his residency at University of Toronto, so he got around. And there he's the leader theme lead for the undergraduate curriculum. So with all that, I'd like to introduce Ed to give us this talk about this interesting population and how we do cancer screening for that population particularly. Ed, it's all yours, my friend.
Great. Thanks so much, Alan, for that kind introduction. And I feel like the title we could have actually elaborated on because we could do 2SLGBTQ plus cancer screening, and we'll talk a little bit about prevention. Really excited to be here, and thank you for having me. As Alan mentioned, I'm a family doctor, and I went into family medicine and primary care because screening and prevention made so much sense to me, and really had a passion for reducing barriers to people who faced challenges in getting care. So really pleased to be talking about that today with a focus in on this population and cancer screening and prevention. I don't have any disclosures and therefore don't have to really mitigate too much bias. So the things that we're going to do tonight are list some barriers to care that the 2SLGBTQ population may face in accessing cancer screening, describe some approaches in creating a welcoming environment, and then really dive into some recommended approaches to screening and prevention for 2SLGBTQ people. And how are we going to do this? I'll talk a little bit about me because I think knowing where I came from goes through some of the resources that I think might be important. Really, we're going to focus a bit on some terminology, and Alan's got our appetite whet just with going over the acronym in and of itself, but we'll do a deeper dive there and some strategies for communicating, because if we can't communicate in a respectful way, it's really hard to provide care. And then we're going to go over prevention and screening for men who have sex with men, prevention and screening for women who have sex with women, or WSW, and I'll talk about those terms as we go along, and then some prevention and screening for trans patients as well. But really, before I get started, want to mention a few things. One of them is the concept of intersectionality, and that, I'm simplifying things tonight just for being clear in communication. So MSM, a man who has sex with men, there's probably a lot more to that person's identity than that, that may afford them some privilege or disadvantage in life. So just really for ease of communication and teaching tonight, we're going to be oversimplifying things, but really I know that as family doctors, we know there's a richness of experience and identity that comes with all of our patients and families too. The next point is that we're always in this ever-evolving language, thinking about how Zennials may speak compared to a Gen Xer like myself. The same is true for the language of 2SLGBTQ care. When I was training, sex reassignment surgery was an appropriate term to use. Now we're using gender-affirming surgery and some other terminology that's a little bit, I would say, more inclusive and kinder. The other thing about screening and prevention with this population is it's kind of this double-edged sword, as you'll find out that, access is often poor or people face barriers, but also there are some things about the population and maybe behaviors that may put them at higher risk. So we'll go into that too. And then one thing that one of my teachers talked about when thinking about cancer screening is just let the tissue or organ system guide some of your thinking or discussions with your patients, and that sometimes helps us move forward in those areas. So just a bit about me. Alan already mentioned where I've trained, and I've done some emergency medicine, but we'll look at Sherburne Health Center in a little bit more detail. And most recently, I was doing primary care at Michael Garron Hospital, which at their family health team today, they had the Minister of Health announce the changes in sick notes. So I hope that's a great change for us all. And now I'm a chief medical officer at Casey House. But Sherburne Health Center, if you're not familiar with it, it used to be the Central Hospital in downtown Toronto. It's located across from Allen Gardens, and really not your typical family health team. It's been around for about 2 decades. Focuses on 3 populations: 2SLGBTQ people who are homeless and underhoused, and people who are new to Canada. About 130 staff and 50 or more volunteers, and really has some unique programming. At the front there, you can see there's a health bus. They provide mobile services to homeless and underhoused people on the streets. But on the second floor of Sherburne, which you can't see there in great detail, is they actually have an infirmary program, and that is kind of like an inpatient ward with 10 beds, and they have 2 beds dedicated to patients who are undergoing gender-affirming surgeries. And a lot of people who are undergoing gender-affirming surgeries might be getting that at Women's College Hospital, which is the Ontario Centre for that programming. But some of you may know that Women's College Hospital doesn't admit people for longer than 23 hours, so that's where Sherburne may come in. The other important thing that I like people to know about Sherburne, besides some of our providers being somewhat celebrities, Sydney Tam there is one of our trans family doctors who was on Oprah a few years ago, and Jake Mossop was one of our former nurses who's on the CTV morning show talking about health, is that Sherburne has created this knowledge translation organization called Rainbow Health Ontario, and they provide training for various organizations on topics like, Gender 101 or Trans 101, and they can specify for various demographics like adults or seniors or children and youth. So have a look at their website if you're interested in getting those trainings. But Sherburne Health has also created the guidelines and protocols for providing trans healthcare and primary care. And that's one of the older versions there in the bottom right. When I was training in 2004 or 5, I had like a draft of this document, and it was for internal purposes at Sherburne. I wasn't even working there, so it was kind of snuck out. But now it's being used as the standard, I would say, across Ontario and Canada, available for free download on their website. So it goes over a lot of what we're going to be talking about today. Another great resource and maybe this is a bit of a conflict, but I probably won't make any money from this, or maybe just enough to have a nice dinner without wine, is a textbook that I helped edit with my colleague Amy Bournes on 2SLGBTQ health. And really, this is a second edition based on the first one, which is about 20 years old. And the chapters are really rich in the fact that we had chapter authors who had lived experience. So our Indigenous chapter was written by a two-spirited nurse practitioner in the North. The disabilities chapter was written by people living with disabilities and accessibility issues. So also has a really great chapter on the history of HIV, if you care to pick it up. As Ellen mentioned, doing some work for Cancer Care Ontario along the way, really saw that there was a barrier for care and a lot of questions about how to include 2SLGBTQ people in cancer screening. And so some of the work that I did with Ontario Health and Cancer Care Ontario was in this area. And at the end of this session today, we'll talk about those specific recommendations for cancer screening that we've come up with. The last thing I'm going to just kind of mention about the work that I do is now I'm at Casey House Hospital, which for many of you, Casey House must have been a hospice and where people went to die, and we focused in on palliative care. Up until about 5 or 6 years ago, we were considered a hospice, but we've moved into more of a hospital. And that sort of reflects the treatments and the success of caring for people with HIV, that people with HIV now can live long, full lives with appropriate care and treatment. But nonetheless, still, people with HIV who there's an overrepresentation in the 2SLGBTQ community still face many barriers to care. We do a program or kind of like a PR campaign every year called Smash Stigma. And a few years ago, we surveyed Canadians and found that over 50% of them would not eat a meal prepared for them by someone with HIV. So this media company that volunteers with us was really bright and had a bunch of HIV positive chefs make soup and send them out to various media outlets. And then a next step was we created a pop-up restaurant where all the chefs had HIV, and this really garnered a lot of media attention to the stigma that people with HIV may face. And we were picked up in all around the world, in England, in The Guardian, in the United States on NBC News and People Magazine, and even Fox News as well. So we're really proud of that work. So advocacy that not only is within our hospital, but outside as well. So really, asking why do we need to kind of talk about this population separately? So certainly there are some health disparities that exist between the 2SLGBTQ community and the general population, and looking at things like income or housing, but also even access to primary care. There is evidence that this population has even poorer access than the general population to primary care, which we know is an increasingly burdensome problem for us all. Many have had negative past experiences with healthcare, and thinking about the trans clients who would wait on a wait list at Sherburne Health. When I worked there, they would wait for many years to see us there. And some would relay these horrible stories of presenting their health card, and their health card picture didn't match their outward identity that day. And reception would laugh at them, or even worse, say that they're committing OHIP fraud and threaten to call the police. So how are you supposed to get respectful care or establish a relationship when that's the first thing that you experience? And certainly there are unique healthcare needs associated with behaviors, and I'll mention that as we move forward as well. And we know that people will withhold information about sexual practices from their doctor in this population, and people will delay care. And as I mentioned, if you were greeted with such derision or contempt at a reception, it's hard to kind of follow up or motivate oneself to get care easily. And that discrimination is often unintentional, but sometimes it has been intentional as well. And there's bias and unconscious bias that we all bring to the work that we do. But some of our patients have actually experienced a refusal to treat. I think that's becoming less and less, and we've done a really great job across Ontario in building capacity and cultural sensitivity and even proficiency in caring for many populations. So but it still happens. One of the things that I like to have is, hearing from our patients. And this is a great video that kind of exemplifies some of the experiences that patients have had in getting care, particularly primary care or other types, but also some of the great things that have happened. So it starts off kind of not so great, but really kind of goes over some of the good things that physicians and healthcare providers have done. So I'm going to play that for us. It's just about 5 minutes, but I think it's pretty important.
A few years ago, I was diagnosed with polycystic ovary syndrome, and the doctors who treated me wanted to treat me as if I was a cisgendered woman who wanted to have kids, and didn't really take into account that that's not necessarily the way I identified or what I wanted.
Early on, after coming out, I had a negative experience, actually during my first pap smear. In the middle of it, started asking me questions about my sexuality, and then giving me quite a lecture about morals and about what was right and wrong to do with sex, and about letting down my parents, all in the middle of the procedure, which was a really sort of traumatic experience.
Just after I was received my positive diagnosis for HIV, I sought the services of a clinic in Melbourne. Basically, the assumption was made that I was just looking for a good night, and basically made the choice of having unprotected sex, when actually the case was I was sexually assaulted, and that's how I contracted HIV.
When I came out, I had a lot of issues with my family and them accepting that, which led to a few years being estranged with my mother in particular. And to rebuild that relationship, we had a few mediated sessions with a therapist, and those sessions became about how I'd left my mother in the dark and how I'd done wrong by her. I ended up in an adult psychiatric ward where the doctors all refused to acknowledge me as trans and used the wrong pronouns, like, deliberately.
I've never had a good experience in healthcare.
It made me feel like I couldn't trust doctors. It made me feel like I had to very much bury who I am and just pretend to be normal, I guess. This experience made me feel really vulnerable and not safe in my vulnerability. Yeah.
This experience made me feel dehumanized. It made me feel like I wasn't worth as much as other patients.
I've had one really good experience with a neurologist that I saw. She noticed that I'd ticked Mr. on the box, but my doctor had put the referral as female. And so she actually spoke to me sort of briefly about that and just asked what pronouns I'd prefer. And when she then had to write a letter again, she checked what I wanted to actually have on it. And that was fantastic.
I had a good experience with a GP who wasn't fazed in any way, didn't blink, didn't act uncomfortable or awkward as soon as I mentioned my partner. And from the beginning, I felt that she understood that I was in a same-sex relationship, that it wasn't particularly relevant to the issue that I'd come there for, but if it did come up, it was something that could come up very easily and comfortably.
Come across a dental practice and they're really caring. They know I have HIV, and they're just very gentle and very considerate.
My message to healthcare providers would be to take the time to really learn about and become comfortable around issues relating to sexual diversity and gender diversity.
If it's out there and we know that people are actually investigating and finding information and they actually understand, that shows that understanding of that, we can actually stop being so prejudiced ourselves and maybe try to find that help.
LGBTI people do go through more issues because we do have to deal with mental health at a higher rate than our heterosexual counterparts.
My message to healthcare providers would be just listen to your patients. If they say that they're trans or they prefer certain pronouns, that doesn't really affect you as a doctor. Just use the pronouns they ask.
It starts with just a dialogue, communicating, and not expecting it to be listed on a piece of paper. It's very important that we have a communication that's one-to-one and that someone is actually listening to what we're saying.
So I just wanted to show that to us because communication is so important in establishing these relationships and providing care. So we are going to go over some terms and some approaches to communication before we jump into those approaches to prevention and screening. And so some of you may already know this, so I hope I'm not being too repetitive or simple about this, but thinking about sex, it's based on biology, thinking of genitalia, chromosomes, and the reproductive system. And then gender is something different. It's one sense of self as being masculine or feminine, and really can include terms like man, woman, gender, queer. And then gender identity is the gender that a person sees themselves as. And this can even be refusing to label oneself with gender. And so sometimes people are refer to themselves as non-binary. A crude way of kind of remembering this, one of my colleagues said, is sex is what's between one's legs and gender is what's between one's ears. When thinking about sexual orientation, really does refer to who we are attracted to, and people may label themselves as lesbian, gay, bi, queer, but sexual behavior may be something different. It's not always an identity or related to orientation. So some men who have sex with men may not identify themselves as gay. And then when we're thinking about the trans community, I always cast my memory back to our organic chemistry days and thinking about molecules and functional groups. And if you had two functional groups on the same side, that was cis. And if they were different, it was trans. And so cisgender, if you haven't heard this term, is someone whose gender identity and gender presentation is consistent with the assigned gender at birth. And for the vast majority of the population, I would say they would likely identify as cisgender. And then conversely, thinking about someone who's trans and that organic chemistry, that the functional groups are not on the same side, refers to someone whose gender identity differs from their birth sex or expresses their gender in ways that contravene societal expectations. Trans is sometimes used as an umbrella term for people who don't conform to gender, non-binary people or gender queer as well. Some of the terminology that you may see in medical literature, like transsexual or transvestite, has really fallen out of favor, so we don't necessarily use those terms any longer. For the purposes of talking today, we're going to divide some of the lecture into these categories of people. And again, really, that there's much more to people than this simple element, but just to convey some points. So MSM, or men who have sex with men, may not necessarily identify as gay or bi. WSW, are women who have sex with women who may not necessarily identify as lesbian or bi. AMAB is assigned male at birth, so someone who may have transitioned from male to female, also sometimes referred to as trans feminine. And lastly, AFAB, which is assigned female at birth, so someone who has maybe transitioned from female to male or identifies as a trans man or someone who is trans masculine. Almost done with definitions, and I know that's a lot. Lastly, just want to mention two-spirited people. Again, another umbrella term associated with Indigenous populations indicates a simultaneous identity of perhaps both masculine and feminine, but can also indicate different contrasting human spirits like warrior and clan mother, or even animal spirits, eagle and coyote. Again, an umbrella term, and many different Indigenous communities have different ways of expressing their two-spiritedness as well. So getting a little bit more specific about language and communication, I remember when I was training in Ottawa in pediatrics, we were looking at chest x-rays and we were looking for pneumonia. And the radiologist said, well, if it looks like your Aunt Minnie, it's probably your Aunt Minnie. And the reason why I bring this up is because in medicine, we're trained to, look for patterns and, recognize different things that, kind of all piece together. And this is something that we're well trained to do and may work for us in many respects. But someone who might look like your Aunt Minnie may not necessarily identify as your Aunt Minnie as well. On the topic of Aunt Minnie, I've talked about Aunt Minnie for so long. There is actually a whole thing about Aunt Minnie for radiologists. If you didn't know, that exists. And if you don't know who that person is in the picture, it's Betty White, not really Aunt Minnie. But as I said before, that that person may look like someone that you think is Aunt Minnie, but may not necessarily be that. And again, that walks like a duck, quacks like a duck thing may not hold true. And in the CPSO dialogue, the most recent edition, it does talk about these cognitive errors that we may have. So really kind of putting things in place that help you not make those errors is something that we'll talk about today. And I've already mentioned the first 2 points there. And then that other 0.3 number there is that some trans people are okay with you using the term trans and some are not. I had a patient who transitioned from male to female, and she said, please don't refer to me as a trans woman. I am a woman, and that's that. So asking is always a good approach. And you saw in that video there, asking for pronouns or what pronouns people use is a really nice and respectful way to get to know our patients. Obviously, language can open that discussion, but it can also shut it down, particularly if you're using wrong names and pronouns. And we all will make mistakes. I have as well. And what we hear from our patients is, yes, acknowledge that a mistake was made in terms of that language or names or pronouns, but just move on. Don't spend too much time on it. Using gender neutral language and asking non-judgmental questions will always set you up well. One of the tips or tricks that I've learned is if you're calling someone in from a busy waiting room and you're not sure what name they use or what gender they're identifying with, you might just use their last name. And I know it sounds kind of like roll call in the Army, but for a lot of our trans patients, that can be quite affirming too. I'm going to touch a little bit on sexual history, and when I was training as well, I think we thought we were doing a good job if we asked if someone had sex with men or women or both, and we thought we were very enlightened, but there's much more to it than that, and this comes from the CDC Guide to Taking a Sexual History, and so it kind of has 3 parts to it. One are the 5 Ps of sexual activity. Who are your partners? Your practices, what are you doing? What are you doing to protect yourself? Have you had previous STIs? And then pregnancy and prevention. And then going on a little bit more in detail, who are you sexually attracted to? And that's where that men or women or both comes in. And lastly, gender identity. Do you have any concerns relating to your gender identity or your assigned sex? And put a note there that this could all be part of an intake form. And a nice part of, primary care when we're meeting patients for the first time is a lot of us do give those intake forms, and having that there just kind of acknowledges that this is, a normal question to ask. And we are acknowledging that people who may have a different gender identity from what they were born exist, or, people may have non-heterosexual partners. And I think that's a nice way of putting that together as part of our system. So also just even nonverbal communications in our office can be important too. Having a symbol that you care for 2SLGBTQ people is important, and putting up a rainbow flag can be quite reassuring to a number of patients. And you don't have to get it perfect, but I'd say try. But for a number of patients and colleagues that I know, and when they see a rainbow flag in an area where they may not expect it, it really does help put them at ease. I already talked a little bit about reception and some of the experiences that our patients have had, and that Rainbow Health Ontario training can be vital to it. And making staff understand that any overt or subtle discrimination is really unacceptable. And then I've already mentioned intake forms as well. So really are here tonight to think about cancer prevention and screening. And as I mentioned before, I'm going to divide it up into MSM, WSW, and trans people as well. So these are the areas that I usually cover when I'm talking about just primary care in general, but they all relate to, I would say, cancer prevention and screening to some extent. So STIs, MSM, men who have sex with men, are generally at higher risk of STIs. And so really doing that good sexual history with the 5 Ps, I would say, is really important. And then reviewing those practices in a lot of detail as one of the Ps. Condom use, really important, and asking about condom use 100% of the time if there's any slips or breaks. HIV risk and testing. There is now prevention for HIV that a lot of our patients are using, and that's a medication called Truvada, which has 2 antiviral or anti-HIV medications in it. And now there's even more prevention or post-exposure prophylaxis that people are using. People who are at higher risk of STIs are using a dose of doxycycline, 200 milligrams, after a higher risk sexual encounter to reduce the risk of chlamydia and syphilis. And the studies have just kind of come out in the past year or two, and really the reduction in risk is about 70% for those. The reason I kind of bring up prevention of HIV is because HIV in and of itself can put you at risk for malignancy as well. When thinking about STIs in my practice, I would screen, for anybody who's sexually active at least annually, but if they're at more risk, every 3 to 6 months. And then not forgetting about the post-exposure prophylaxis for HIV if someone is having an unsafe sexual encounter. I think really important for this population, the men who have sex with men or gay or bi identified people, are immunizations that sometimes get a bit forgotten. Men who have sex with men are at higher risk of hepatitis A and B actually. One because of oral fecal exposure, but also B because of the possibility of mucosal trauma of anal sex. And that also puts one at risk of hepatocellular carcinoma. So the vaccines from most public health units, I have TPH there, Toronto Public Health, but I'd say most of them across the province are covered. So that's nice. I check serology after vaccination. I don't think that's as evidence-based, but I would do that just in case people are moving around and can't remember what vaccines they've got. But also the HPV vaccine, nonavalent, is now covered through a lot of public health units as well for ages 13 to 26 for gay, bi, and trans or trans women. And so one of the other things that I'd like to point out is the National Advisory Committee on Immunization a few years ago came out kind of with a softer statement that consider offering the HPV vaccine to any man who has sex with men because the risk of anal cancer and head and neck cancers are quite high. And here we have anal sex as a risk factor for HPV-related anal cancer. Thinking about the prevalence of HPV-related anal cancer in the general population, I think it's about 2 per 100,000. But when you look at MSM, it's about 30 per 100,000. And then when you look at people who have HIV who are MSM, it's about 70 per 100,000. So dramatically higher rates of anal cancer. And if we have a vaccine that can reduce that risk, why wouldn't we want to look at that or offer that at the very least? And we get asked a lot about anal PAPs too, and there's not really any widely accepted screening recommendations in this area, but we're kind of getting to a point, and I'll mention a study in a moment, in which we are likely risk stratifying people. So as I mentioned before, HIV positive men who have sex with men are probably at the highest risk. Some would argue as well those that are older are at higher risk. And so thinking about screening is a reasonable thing to do. There was this study that came out about 2 years ago called the Anchor study that had about 4,000 patients in it. It was an RCT. And researchers found that by removing HSIL, the chances of progression to anal cancer were significantly reduced. But again, I think we need to see a little bit more evidence before we have these broad recommendations. But if you are caring for HIV positive MSM, I think it's a reasonable conversation to have with them. If you've never done an anal PAP, I believe the University of California, San Francisco site, which I'll show you at the end, has some instructions. And UpToDate does as well too. There's also an anal dysplasia clinic at UHN, which not a lot of cities have. Going to move into cancer screening and prevention for WSW, or women who have sex with women who may or may not identify as lesbian or bi. Cervical cancer screening is one, breast cancer and breast cancer screening, and smoking cessation are the topics that I think are most important to consider when working with WSW. Many years ago, we actively told WSW or lesbian identified patients not to have pap smears. It was thought that the risk of cervical cancer was negligible or zero. I don't know where that came from exactly, but that was really wrong. And as I think many of you know, that if you've ever been sexually active, and that includes oral sex, sex with toys, or sex with fingers, and have a cervix, you need a pap test. And the OCP, or the Ontario Cervical Screening Program, starts at 25 now, so you'd start then. There was this great website called checkitout.ca that focused in on queer, lesbian, bi women, encouraging them to get PAPs a few years ago. And I think they've just moved it to Sherburne Health, if you want to check their website out too. The other area is breast cancer. And the risk of breast cancer in women who have sex with women, or people who identify as lesbian or bi, has been widely debated. And it was thought to be actually higher because of some risk factors like lower rates of screening, nulliparity, and there is a documented increased average BMI and higher consumption of alcohol in this group. In my discussion with some breast cancer experts, they've not really ever seen any indication to screen at a different interval or in a different way than what our regular screening guidelines are for heterosexual women. But it is a certain thing to consider in terms of risk reduction, talking about alcohol and other factors that may increase one's risk for breast cancer. So keeping that on your radar in our periodic health exams and just regular care, I think, is important too. Lastly, for WSW, but kind of for all of these communities, they likely smoke at higher rates than the general population. We do know that women who have sex with women do smoke at far higher rates than men who have sex with men and the general population. So we all know that smoking is a huge risk factor for many malignancies. So working on this, as we would do with any of our patients, is recommended. But it's not a surprise that the 2SLGBTQ community does smoke at higher rates. They're specifically targeted in lots of marketing in years past. And I think that's not as true today, fortunately. I'm going to round us out thinking about our trans patients. And really, they face many different barriers that even gay or lesbian or bi patients might, like healthcare providers may not know trans people themselves or don't think that they know them. And really caring for trans people may not have been a component of medical school education, but we are doing a much better job at that now. And sometimes a lack of awareness leads to poor access. And sometimes it's not intended at all. It's just not being aware. Also, there's an absence of trans-specific guidelines. I talked a little bit about how the Sherburne guidelines, in 2004 and 5 were draft and only for use within one organization and not to be circulated. Fortunately, we're doing better at having more available guidelines and better evidence as we move forward. But we do still see some system-level data issues. And there's a researcher at the University of Western named Greta Bauer who does a lot of research in the healthcare of trans people, and talks about this concept of systemic erasure, and that we're not able to get a good sense of trans people's healthcare and their experience in the world because we don't often ask about that identity. And it's also for some trans people, they've had such poor experiences, they may not want to disclose that. So we may not have a good understanding. And so that's called systemic erasure, and that may not have allowed us to have the best evidence available. But that is slowly changing. For instance, the census about a year or two ago actually for the first time included asking people about trans identity as well. So slowly, I think we're going to get better guidelines and data as we move forward. So I've divided this into screening for trans feminine individuals, sometimes who may identify as non-binary, and trans masculine individuals also may identify as non-binary. So we're going to start off with trans feminine people. So this is someone who may have been assigned male at birth and transition from male to female. And so starting off with breast screening, this is probably the furthest departure from what we would recommend or what you have seen in the past. And so if you have a trans feminine patient who has a history of 5 or more consecutive years of cross-sex hormones and are between those average risk screening ages of 50 to 74, the recommendation is screening every 2 years with mammography. And so cross-sex hormones can be a number of different things. Usually it is estrogen, but also often paired with progesterone, not so much in Canada, but also a testosterone blocker like spironolactone. And then for trans feminine patients who are high risk, and that high risk program, which I was really pleased to see CCO implement several years ago, is generally for people who have a lifetime risk of breast cancer of 25% or greater and are between 30 and 69. So any trans feminine patient who meets that criteria and has that history of 5 or more consecutive years of cross-sex hormones, you can refer to the high-risk Ontario Breast Screening Program. And if you're not as familiar with the high-risk Ontario Breast Screening Program, that offers mammography and breast MRI on a yearly basis from 30 to 69. One of the changes that's come to light in the past few years with the Ontario Breast Screening Program that has been a change for everyone is it used to be that anybody who had breast implants was excluded from that type of organized screening. And a number of our trans feminine patients had breast implants. And so this was a nice change that has occurred recently to include anybody who has breast implants. I'd just like to make a few points on breast cancer in trans feminine women. And if you do have some trans feminine women in your practice, we tend to really, rightly so, advise on the risks and benefits of hormones. And I think the Women's Health Initiative sensitizes us to that. It's thinking about menopause and cisgendered women, but also when we prescribe estrogen to other people, and for a lot of trans feminine women, that's part of their care plan. So we may probably overestimate the risk of breast cancer in this population. And really, there's been very few recorded cases. Admittedly, these studies have been retrospective. There was one study in the US from the VA that looked at about 3,500 trans feminine women and found that there were only 3 cases. So I think that's quite low. And some factors that may reduce the risk is less lifetime hormone exposure. And as I mentioned before, we don't usually use progesterone in Canada and North America, so that likely plays a role too. Some of the criticism about these studies too is that a lot of the people involved, the patients, were not offered organized screening, and that's something that at CCO we've been working on for several years. Moving on to cervical screening in our trans feminine patients. So cervical screening for someone who was assigned male at birth or born male and transitioned to female really doesn't make sense in a lot of ways. There have been some surgical procedures somewhere in the world that I've never seen that have created a new cervix for people. Again, very seldom done, and the tissue would be different. So from a scientific point of view or clinical point of view, it's not really indicated. But if you do have trans feminine patients and they've changed their health card from male to female, they may get the correspondence from Cancer Care Ontario telling them that they're due for their Pap smear, which for some of our patients is very gender affirming and welcome, but also when you keep getting letters to remind you, kind of becomes annoying. And so you can actually tell your patient to call the number at the bottom and get removed from that because they don't need cervical cancer screening. The last group of people I'm going to mention are transmasculine patients. And so again, getting back to that principle of if there's a tissue or organ system there, consider screening it. And so for a lot of patients who may identify as transmasculine, they may not have had mastectomy. If you've had bilateral mastectomy, you're not eligible for the Ontario breast screening program. But if you do have breast or sometimes transmasculine patients prefer chest tissue. And again, that's getting into that conversation about what words people prefer. If they do have chest or breast tissue, it's that regular recommendation of mammography for average risk every 2 years between 50 and 74. And then similarly, if someone is at high risk, referring them to the Ontario breast screening program. I have had some transmasculine patients who have undergone bilateral mastectomy or chest reconstruction surgery or gender affirming surgery. So they have very little chest or breast tissue, but had been deemed to be higher risk. And so in speaking with some oncology specialists or breast specialists, we've come up with a non-evidence-based plan, but it sometimes included yearly ultrasound, which from a broad public health perspective, we don't recommend, but also MRI. And so coming up with a tailored plan for that particular individual is what we did in that circumstance. Thinking about cervical screening, as I mentioned before, regardless of one's gender identity, whether you're transmasculine or cisgender woman, if you have a cervix and are sexually active, we recommend screening every 3 years. If someone is transmasculine and getting gender affirming surgery, the experts recommend doing some screening before removal of the cervix. And if you are doing a PAP or cervical screening with someone who is trans and on something like testosterone, mentioning that on the requisition is important because there are changes to cytology that can be misinterpreted as well. I think that takes me to the end of what I wanted to go over tonight. As I mentioned before, Sherbourne has some great resources, which also includes Rainbow Health, and both those websites are there. British Columbia has their own provincial health authority with a robust area there too. And I mentioned the fourth item there is the University of California, San Francisco, great guidelines for trans health, but also anal PAPs. And as I also mentioned, Women's College is our local Ontario-based program for transition-related surgeries, and a lot of trans care is going on there these days. So I'll stop there, and certainly glad to take questions, or if you want, email me, glad to answer that way.
And thank you very much for that really comprehensive talk, and I certainly learned a lot. There was a couple questions. One is overall, we'll be sharing the slides. There will be recording and information sent out to all the registered people at the email you registered. I mentioned that at the beginning. Practical question, because physicians are small business people, how do you bill for anal pap smears in men who have sex with men? Will they pay for it? And similarly, along the same but different direction, is those people who are not eligible for pap smears for the reasons you discussed, who get the letters, is that going to affect their ability to get their bonuses and things like that in terms of the ratios of people who are not having the test done? Have you run into that as an issue in your practice?
You know, I've never been asked about anal paps for men who have sex with men and billing. So what I think, you know, you could try, well, one, I don't know if the province or Ministry of Health thinks of it as a different procedure. So there, because you're sampling not the cervix, but the anal canal. So I can't, you could try, and if it gets rejected, you could maybe ask for individual review. And that sometimes is, you know, an approach. But, you know, I don't think that, is it G365 from my memory? I don't know if that was intended for anal pap. So there may not be a code. And I think that reflects, our lack of evidence and moving forward. And Ontario Health and Cancer Care Ontario are really great at advocating for changes to OHIP billing, but it does take quite a bit of time. So I think as we move forward in time, we'll get a better sense of that. The question about people not being eligible and getting correspondence, calling that number on the bottom of the correspondence to get removed from the list is what I would do. And then I believe, and again, this is maybe a question for you, Ellen, and the people who do the data. When I was doing more primary care and submitting my cancer screening bonuses, I believe if you change your gender on your health card, so you may not be getting. I'm trying to think if someone, or actually the example was, if someone changes from male to female and doesn't have a cervix, so they may be counted in the denominator of your screening activity report. Again, I don't have a great explanation for that, but I think you could look at, I don't think that you have to use your SAR data, and if you have a better way to exclude it, you could perhaps try to use one of the exclusion codes that are listed in the OHIP billing codes is maybe another approach too. I would estimate that it's probably a very small number for each of us, and even in my practice that had quite a number of trans individuals, it really wasn't a problem. But yeah, well, if it made the difference between getting from 69 to 70 or whatever, I think you could probably argue that.
Yeah, so I think any billing code changes will be a long time, and I agree. I think I would try to do the billing, but more than likely it's going to be rejected. You may have to speak to someone, and of course it just sort of speaks to the resources and stuff they're needed. Obviously, you don't need a speculum to do this, and I'll have to have a look at the technique and in the information you mentioned on how you do that, or maybe even want to describe that quickly. In terms of bonuses, actually, I took you down a rabbit hole there actually unintentionally, because they've actually removing the bonuses for us this year. So, but that doesn't change the fact that we're still looked at how we do in our practices and how you're doing in terms of percentages. So we still all want to be able to come up with a good number. Do you want to spend a second talking about anal pap smears and how it's actually done? So say people go into the video.
Sure. Yeah. And maybe qualify it a little bit even more so in that I would have a conversation with my patient about it. So again, this was, a risk stratified group. So it was only like my men who have sex with men who had HIV who I would have the discussion with, because that's where the risk is highest. And so I would also talk about, because a number of providers who have a good number of patients who are MSM, who have HIV, who do anal PAPs, get these results, and we don't know exactly what to do with ASCUS and how to follow them. So speaking of rabbit holes, that can put you into a rabbit hole as well. So in a lot of the talks that Alan has probably given you, there are risks to screening, in particular this one too, that you may be referred on or have a lot of anxiety for something in which maybe not really relevant to your health. So I had that discussion, but for people who place a high value on screening, it may be quite reasonable to do. Usually it is using a Dacron, that sort of Christmas tree shaped cyto brush. You wet it and insert it about, I think it's 4 to 5 centimeters, and twist it, I believe, 5, 6 or 7 times. And then put it into the liquid base is the approach. And again, this is something that people, I would say, in some clinical contexts do regularly. I know in British Columbia for a while they were doing it. In the Ontario context, I'd say it's hit or miss in terms of providers. What I would do too, if you don't have a ton of experience in that area, is maybe speaking with, if you are caring for HIV and have a good deal of knowledge in that area, go for it, or look at some of the BC guidelines, or speak with your infectious disease specialist who may be caring for that person to see if they have an opinion on it too.
Yeah, it's interesting because we have set up follow-up for abnormal PAPs with colposcopy referral, but I'm not sure who the referral is going to go to with an abnormal cell type in that group. It'll be some of the general surgeon, I'm sure, and who may not have set up for a colposcopy of that part of the body.
Yeah, absolutely. And so in terms of general surgery is generally a place where people would go, but the UHN has an anal dysplasia clinic, but they are quite busy and full. So it's really hard to get in there, and far for, I would imagine, a lot of your patients too in your neck of the woods. So again, so that's why I kind of think about talking about the risks and benefits of screening too. And again, it's kind of an unsatisfying part of cancer screening that we have right now, but we still really do need a little bit more information to give better guidance on this. But for someone who, as I said before, who's HIV positive, MSM, might be at an older age, it might be reasonable to have that discussion with them, talk about those risks and benefits.
Okay, excellent. I mean, absolutely. And of course, HPV screening is coming, so that will actually change how we do this as well.
Yeah.
So having the HPV subtype that's more oncogenic might be take you down a different kind of direction, as you said.
Yeah. There, some of the jokes at the HIV conference are that because of HPV vaccination, there's less, cervical cancer, that the colposcopists could maybe transfer their skills to anal cytology or dysplasia, and look at that. Anyways,
okay.
that's
good. That's going to be very confusing in the colposcopy clinics, I'm sure.
I bet.
All right. Well, listen, thank you so much. I don't see any other questions up on the board there. If anybody else has a question and wants to unmute themselves, please go right ahead. Give you a minute to do that.
Sorry, Dr. Kaplan, I do see a question from Chelsea Butler. I'm not sure if you see it on your end.
I do not.
Okay, I can read it out for you if that's
Please.
okay. I work with folks who are looking for colorectal cancer screening or living with colorectal cancer. I often get the question about whether there is a list of inclusive practitioners who complete colonoscopies. I hear from folks that it is often very uncomfortable with healthcare practitioners who are ignorant. Do you know of such a list, or perhaps can speak to that a little bit more?
Yeah, I think that's a really great point that I didn't touch on, so I'm glad you brought it up. And this is true for lots of things. So, for example, if you had a trans-identified male or trans man patient, and you're referring them to the breast clinic or for mammography, my approach is to, find those places that are enlightened or have had that Rainbow Health Ontario training, or even have that discussion calling ahead and say, that this is a trans-identified person. We want to set them up for success. They prefer, he and him as, or their pronouns are he and him. And so doing some things like that. Also in referrals, I often will ask patients, is it okay if I disclose, that you're a trans man, you're on testosterone, these are your pronouns, please refer to you as this if their health card is different from the name that they use. But to your question about, is there a list for, people who are really great at providing care to 2SLGBTQ people? I believe there is at Rainbow Health Ontario. There also is the 519 Community Center in Toronto, and I've seen physically on their wall that there's a list of providers. But I think in terms of specifically for colorectal cancer screening, I don't have anyone off the top of my head, but again, that sort of approach of, calling ahead and seeing what someone's experience is, or if you have a specific question about a specific patient and they're in a specific area, I'd be glad to see if I can find someone. I have providers that I, generally refer to in my area that I know treat our 2SLGBTQ people well. So, maybe I could drop one of those names to you. But again, Rainbow Health Ontario may have a listing.
And if we ask them often enough, if they don't have one, they'll probably create one, and that'll probably solve a lot of that problem. All right, I don't see any other questions. Brianna, if you don't see any other either, I think it's probably about time. We're up in our hour. Ed, once again, thank you for a fascinating review of how we can look after people that are having trouble getting the care that they want and need. So thank you so much for really reiterating how we can do this appropriately and compassionately, and thanks to the CCO team for putting it all together for all of us tonight. So with that, I think I'll say good morning, good evening, good night as per Truman, and be well, everybody.
Have a good night. Thank you.